Hey guys, it's Sarah here. In this video, I'm going to be going over a mental health portion of the NCLEX-RN. So before I get started, I just want to let you know that all this is available in a PDF form on my website, sararn.com, or in the link below. So let's get started. Okay, so before I actually start on this, I'm just going to say one thing, that when we talk about psych in specific, a lot of stuff there's normal, and then there's like a spectrum, and then it becomes abnormal. So say, for example, phobias, like we have on this page. So phobia is an irrational, persistent fear of something. So let's say you look at the first one, school phobia. So school phobia is basically an irrational, persistent fear of school. So when you think of your kid, your 5-year-old kid not wanting to leave you and only want to stay with you and not want to go to school, you'll be like, they have a school phobia. But that's not school phobia. Phobia is like I said, it's a spectrum. So if your kid doesn't want to go to school and wants you, that's not a phobia. This is like an extreme of everything. So school phobia is an extreme separation anxiety that happens in elementary school, that they have a persistent irrational fear of going to school or being in a school-like atmosphere. So if this happens, basically you don't want to keep the kid home. You want to have the child go back to school because it's just going to get worse. Acrophobia, just know that's fear of heights. Claustrophobia, we all probably know this, is fear of a closed-in space. Agoraphobia is a fear of being outdoors or being in a situation that somebody can't escape from. Zoophobia is fear of animals, and social anxiety disorder is basically they have so much anxiety and fear of being observed or embarrassed in a social settings that they don't go out or they're prevented. So all these people like this is really interfering with their activities of daily life. They don't want to go out because they're afraid of this happening, or they don't want to go into anywhere inside because they're afraid of closed space, like stuff that are really irrational. So for all phobias, no matter what type it is, you want to basically systemic desensitization, which is basically you want to gradually expose them back to it. You don't want abstaining. You don't want to say don't go back to school or don't go to animal zoos. You want to like expose them like here's a cat, this is that, and like slowly, 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 so that they could function in society. Okay, stress disorders. So there's an acute stress disorder and PTSD. So acute stress disorder basically happens after a traumatic event. So does PTSD, but the difference between those two is that acute is less than 1 month, and PTSD means that it happens more than 1 month. So for acute stress disorder, some symptoms are going to be dissociative symptoms. They have sleep disturbances. They have difficulty concentrating. Number one you want to do with this, you want to assess for self-harm. No suicidal thoughts or anything like that. You want to assess for ineffective coping, like they're using alcohol or drugs for their coping. And you want to assess how it affects their daily lives, like their relationship, etc. You want to tell them that this is normal and help them cope with different strategies, help them discuss, etc. So like I said, if this happens more than 1 month, it's PTSD. There are 3 categories of PTSD. Number one is experiencing the event, so they'll have like flashbacks, recurrent nightmares of whatever happening. Number 2 is avoiding reminders of the trauma, so that's they'll like avoid places that remind them of, or that if something happened in the grocery, they'll avoid going to groceries, like that. Number 3 is increased anxiety or emotion, so they'll have anger, fear, they won't be able to concentrate, insomnia, etc. So number one, so what you want to do with PTSD is you want to discuss a traumatic event. So don't not like with anxiety, just discuss it so that it shouldn't be kept in them and it bottles up. You should, assess their readiness to talk and then discuss it at their pace. Always assess for suicidal ideations, and you could give them antidepressants and support, etc. Okay, anxiety disorder. So anxiety disorder, panic is basically a sudden intense fear, like all of a sudden like they panic, like when you have $1,000 and then you lost it, you panic like that. OCD is obsessive compulsive disorder. So this is a combination, like the name says, of obsession, so they have like persistent thoughts, and compulsions, which means like doing repetitive behavior. So the thing about this is that over time it becomes very time consuming and it interferes with the daily life. So like you'll keep hearing me say interferes with the daily life because that's like really like the tick of point of where it becomes like a disorder. Like it's interfering with their daily life. It's not irregular, like scared or panic or doing the same thing again, you know. Generalized anxiety disorder is excessive worrying, like completely out of proportion to what, you know, they should be. A separation anxiety disorder is excessive anxiety from separating from a person or a home, etc. This is actually very normal in childhood, but not in adulthood. Okay. Okay, so schizophrenia. So schizophrenia is hard to actually define in like a sentence. It's basically a complex brain disorder that has a combination of symptoms. Like they're basically distorted thoughts and they do not perceive reality. Risk factors, so 50% of it is actually genetic, and the other ones are like prenatal factors, reduced brain size, etc. What I would know is the positive and negative symptoms, which are present with schizophrenia. So positive symptoms are the presence of something that's not normally there, and negative symptoms are the absence of something that should be there. So for instance, a positive symptom is hallucinations, delusions. Normal people don't hallucinate, they don't, you know. Negative symptoms are something that should be there. So for example, someone with schizophrenia could have a flat effect. So normally someone, you know, you say something, they'll have expression. So someone with schizophrenia will just stare at you. Normally someone will enjoy something, they won't, anhedonia, etc. They also have cognitive symptoms like illogical thinking, bizarre behavior, and very poor decision-making skills. What you want to do for them is, so always with psych, the first thing you want to do is make sure they're not suicidal. So for schizophrenia, because they're having the hallucinations, you want to make sure that they don't have command hallucinations. And command hallucinations are basically voices in their head telling them to do something. For example, jump into the river like that. And that would be suicidal. So you want to assess for that. Number 2, you do not want to argue with their hallucinations or the delusions. Never argue with them. You just want to like switch the topic to a reality-based topic, but don't feel like that's not true. And don't encourage it either. Don't be like, oh, that's really cool, the Superman or whatever it is. Just kind of like switch the topic into something reality-based. The treatment for them is usually antipsychotics and cognitive behavioral therapy. So delusions are false fixed beliefs that cannot be corrected with reasoning. So for example, if they have a delusion, you can't just like explain to them why it's not true with reasoning. They won't hear of it, so don't even try that. There are different types of delusions. So number 1 is delusion of reference. So they believe that everyday things are significant to them. So for example, they'll hear a song playing outside and they'll be like, oh, that's a secret message to them. Or delusions of the grandeur. So that's basically they believe that they have a power and they're really important. So they're like, oh, I have to go to Washington to meet with the president today, you know. Delusions of control is basically that they think that they're being controlled by everybody or even like one specific person. So you'll give them a drink and they'll be like, oh, is that something poisonous in there? Even though it's just plain water. Nihilistic is basically that they think that they're dead and life doesn't have any meaning. They'll be like, I'm already dead or something like that. Somatic is they have false beliefs about the body. Somatic always means the body. So they'll be like, the doctor says I'm fine, but really I have heart failure. And the last one is persecutory. So these are beliefs that they're being threatened or treated unfairly in some sort of way. Like they're trying to poison me with tap water. Kind of like the same thing as they're being controlled. Okay, a question. So a group of community nurses sees and plan care for various clients with different type of problems. So which of the following clients would they consider the most vulnerable to PTSD? So number 1, an 8-year-old child with asthma who has recently failed a grade in school. Number 2, a 20-year-old college student with diabetes who was raped. Number 3 is a 40-year-old widower who recently lost his wife to cancer. And number 4 is a wife of an individual with severe substance abuse. So B is usually caused by extreme, like a specific trauma, like a rape or something like that. Not stressful stuff, just like trauma. Okay, now we go on to depressive disorders. So suicide is a big thing. Number 1, always assess if the patient is suicidal. If they are, the next thing you want to always do is ask them if they have a plan. The risk factors for committing suicide, number 1 is that men, because men actually commit more, women attempt more, but men actually do the whole thing and commit it. Teenagers are at risk, people who are depressed, history of suicidal attempt, drug abuse, someone with no support system, no significant other, and unemployed. And this is important to know because you want to know who's at risk to, watch out for them and think of asking them. What you want to do is never ever leave a patient alone if they tell you they're suicidal. You want to place them on a one-to-one supervision. Even when they go to the bathroom, they go on a one-to-one supervision. And they should be in a room without something that they could use, like without wires that they could strangle themselves, etc. Major depressive disorder. So this is basically 2 or more weeks of constant depression. The person must also have 5 or more of the specific symptoms. So it's not just regular depression, you failed, etc. What you want to do for this is you want to assess the person first for suicide, because like I said, it's a risk factor for suicide, and you want to assess the support system. You could give them antidepressants, and electroconvulsion therapy could also be used, but it's not quite really used a lot. You should just know that a patient with major depressive disorder could have psychomotor retardation, which is basically like a slowing of motor activity related to depression. They won't have energy to perform regular like life stuff, Okay. Insomnia, I guess I wrote it here, but it's supposed to be a separate topic, is quite common and it happens with depression a lot. What you want to do is you want to reduce the stimuli in the bedroom, so no like TV. You want to tell them no naps later on in the day. You want to keep the bedroom cool, quiet, dark, no caffeine, alcohol, something that won't allow them to go to bed. Don't go to bed hungry because that would also keep them up. You want to have them like yoga, drink warm milk, or eat something like carbohydrates before bed. Okay, bipolar. So bipolar used to be called manic depression, but now it's called bipolar. It's a mood disorder that's characterized by mood swings. So they'll go from extremely high, like mania, to extremely low, depressed. When they're in the mania, they're extremely high, they'll have inflated self-esteem, grandiose thoughts, racing thoughts. They'll just keep talking, jumping from one like flight of ideas. Really bad impulse, etc. When they're the low, they'll go really low. They'll be like depressed mood, they'll gain weight, they'll have no energy, they'll be not interested in anything. What you want to do is, number 1, you want to limit the amount of people in contact with them, one-to-one interaction, so no group activity because they don't do well with that. You want to have schedules for them, set limits on behaviors, like don't let them just take a credit card and go with it. You want to get them, a lot of them, when they're in the manic stage, they won't eat because they'll just be like jumping around and they won't eat. So you want to give them like protein bars or like small stuff that they could take with them. And of course, you want to assess for suicidal ideation. The main medication that's prescribed is lithium. Okay, delirium, dementia, and Alzheimer's. So let's start with dementia. Dementia is basically a generic term that refers to age-related mental decline. Included in this is Alzheimer's. So Alzheimer's is a part of dementia. It's not a separate thing. Alzheimer's is actually the most common form of dementia. So that's why we're only going to be talking about that. Causes are, a lot of it is genetic. Lifestyle causes could also be, and environmental. It's usually diagnosed after age of 65. Early onset would be considered if someone was before 60 years old and diagnosed. There are a lot of different stages where, like the first few stages, they're completely with it, they're functioning on their own, and when they keep going, they need like an aid, they can't feed themselves, etc. Intervention. So first of all, you want to prevent them from wandering and getting lost. You want to place locks leading the house. You want to have alarm when they go off, stop sign, stuff that could tell other people that they're leaving. You also want to have cold and hot labels so they don't like forget that this is really hot and then burn themselves. You want to remove household hazardous stuff like rugs, toxic chemicals, and you want to keep the medication out of reach because you don't want them, to just take all their medication forgetting that they did it. You want to arrange the furniture, you want to label the bathroom door, so doors that they need, and speak to them slowly and simple words. Don't have like open-ended questions, because then they're never going to answer that. Safety, pretty much with these patients, the key is safety. So all these stuff that you're doing is basically for their safety. With dementia patients, they could sundown, which basically means that they'll be fine in the day, then all of a sudden at night they'll have increased confusion at night. So just know that. So next we go on to delirium. Delirium is basically, it's when they have a mental status change, you'll think they're demented, but they're really not. It's really acute and it's very reversible, and it usually is from an illness. The most common one is usually like a UTI in an elderly woman or man. They'll come like delirious and someone will think that they have dementia or something. They'll talk about things nonsense. They'll not know what they are. This is usually due to either medications or UTI, etc. The priority with them is also safety. You want to place them near you, frequent reorientation because you don't want them to get up when they can't even walk, and the solid rate, you want to place like the rails up and stuff like that. Just orientation and make sure that they don't hurt themselves. Okay, a question. So a nurse discovers a patient's suicidal note that details the time, place, and means to commit suicide. So what should be the priority nursing intervention and rationale? So number one, give them Ativan, which is a sedative, because the client is angry about the discovery of the note. Number two, establish room restrictions because they're a threat. Number three is place this person on a one-to-one precaution. Number four is calling emergency treatment. So the nurse's priority should be that the client will remain safe during the hospitalization, and safety is always precaution, and you always want to place the patient in a one-to-one. Okay, childhood disorders. So number one is ADHD. ADHD is attention deficit hyperactivity disorder, and this is basically someone has inattentiveness and impulsiveness. So their symptoms would be exactly like that. They have difficulty concentrating, they'll have excessive activity is basically their symptoms. The thing you want to know about this is that usually they'll have hard social time, they'll see a lot of like critical judgment, and they'll have a low self-esteem, especially because they don't do well in school, and they're at risk because of that for depression and substance abuse. So for this, you want a team approach. You want to get the whole, like their teachers involved, their parents involved. You want to advocate for services for them, and you should just know that even though it's like a childhood disorder, they never outgrow it even when they're older. And you should also know that when people say like, oh, less sugar, it won't improve the symptoms. So you want to really give them medication like stimulants. The next one is autism spectrum disorder, and that refers to a group of complex neurodevelopment disorders. And what's characterized by repetitive and characteristics of behavior, and they're very difficult to socially communicate with. Symptoms, they're hypersensitive to sound, touch, and like senses. You want to put them in a very calm environment with no stimuli. A lot of hospitals will have like a sensory room for them. They need structure, consistency, and don't give them choices because it's very overwhelming for them. Okay, personality disorders. So the way it works is that they're divided into cluster A, B, and C. A is all odd and eccentric. So paranoid, they have a distrust and suspicion over others. They're very difficult to get along with, and they need to be like in control of everything. For them, you do not want to be too friendly or too nice to them. Just you here, there, bye. Schizoid is when they're socially detached. So they don't express emotions, they want to be alone. Don't try to increase their socialization. This is how they are. And schizotypal, which is extreme anxiety in social situations. You want to respect their needs for social isolation. With this, magical thinking is pretty common. So this is cluster A. They're all like odd and eccentric. Cluster B is dramatic or emotional. So antisocial. So antisocial is not what you think it is. Antisocial is a disregard for others' rights and rules. They're very manipulative. They're very irresponsible. They blame other people. What you want to do for them, you want to set rules and firm limits. They should take responsibility for their own actions, and you should just know they have a huge problem with authoritative figures. They don't like to listen. They like to do their own things. So you want to show them who's in control. The next one is borderline. So this is when they have an unstable, intense relationship, distorted self-image, extreme emotions, and they're very impulsive. For them, you want to provide clear boundaries, clear communication, and assess for self-mutilation. The next one, narcissistic. So that you probably know is basically grandiose. They have a sense of entitlement. They have no empathy. They think that they're superior, and they act superior to cover up for their emptiness. Basically, they have like a damaged, frail ego from childhood and poor self-esteem. So they develop this like narcissistic behavior to cover up for it and protect their ego. The next one is histrionic. So histrionic is someone who needs attention, very shallow, someone who dresses to get everyone else's attention. They want everyone to look at them. They do whatever the heck it takes for everyone to give them attention. They get their self-esteem from others and from others' opinion. They're inappropriate, they're provocative, they're into their physical appearance. They have a very difficult time maintaining relationships. The next cluster is cluster C. That's people who are very anxious and fearful. So this includes someone who is dependent, they're excessively clingy, they need to be taken care of. They live in like fear of rejection, so to avoid being like abandoned, then they manipulate people to prevent someone from leaving with them. They can engage in like suicidal behavior or even harmful behavior just to get some to prevent the other person from leaving. So for this, if the patient's there for a while, you don't want to assign them the same nurse because they're going to get dependent on them. So you want to keep switching it. The next one is obsessive compulsive. So OCD, people get OCD from stuff, but no one has OCD unless it really interrupts you from your daily life. Like you cannot leave to even go somewhere because you have to do this. So for this person, you want to help them get involved in other activities. You want to help them identify what causes the anxiety, give them positive reinforcement, cognitive behavioral therapy, etc. And the last one is avoidance. It's basically someone like social inhibition. You want to maintain like a friendly approach to them, but allow them to be separate and don't push them into social places. So basically with all these stuff, clear, firm rules, don't let them overtake you, show them who's in charge, and don't push them into whatever they don't want to be pushed. Okay, eating disorders. So the first eating disorder is anorexia nervosa, which is basically anorexia. So this is an extreme fear of gaining weight and altered perception of their own weight. So they'll be very thin, they'll won't eat because they'll be afraid of gaining weight. They think they're fat even though their BMI is like too thin. They usually lose their period. They're preoccupied with thoughts of food. So all day they could just think of like their food and what they're going to eat and what they're not going to eat. They usually have a very low pulse. They're usually hypotensive. So you want to watch out for EKG changes for them because they'll have electrolyte imbalances. So think of potassium. That's a big one with them. If they're suicidal, they obviously need to be hospitalized. Interventions for them. So you always want to restore the electrolyte imbalance because they're going to have because they're not eating. Do an EKG and treat the medical condition. You want to weigh them every morning. You want to have a weight goal of gaining 2 to 3 pounds a week. You don't want to focus on food for them, like don't keep talking about food. But obviously it's going to be in the equation. You want to help them, basically your goal is to help them to develop effective coping strategies that they don't have to go back to this. The next one is bulimia nervosa, which is basically binge eating. So they'll eat like a ton of food, they'll binge, and then they'll vomit to get rid of all the calories. They, not all of them vomit, maybe some of them, it's like basically a binging eating. So they'll binge, but not necessarily vomit. So they could exercise to get rid of it, they could use laxatives, they could vomit, whatever the heck they do, but to get rid of it. Symptoms, they'll also have electrolyte imbalances, but for them, they'll have a normal body weight because the reason why they'll have a normal body weight is because they're eating. The person with anorexia is avoiding food. So you might not catch them right away because they're usually secretive and they usually look like a normal weight. But you can look at their hands, they'll have calluses from their hands from doing the vomiting. Their teeth will be like a little bit bad because they'll try to, erosion of teeth and enlargement of parotid glands. For them, you want to remain with them when they eat and for 1 hour after to make sure they're not vomiting. You want to monitor the electrolytes, counseling, education. Okay, restraints. So there are different types of restraints. There are chemical restraints and physical restraints. So for restraints and people who are getting violent that you need to restrain, number one, you always want to do the non-invasive stuff first. You always want to have clear communication, de-escalation, etc. The last resort is restraint. Chemical restraints are medicating the patient with like a benzodiazepine, like Ativan, basically to make them sedative and restrict their movement. If you need to, there's physical restraints, which is another way to basically hold the patient. These are temporary. You have to keep checking on them, release them, because you don't want them to get like a pressure ulcer if it's too hard or something like that. You want to provide skin care, range of motion, assess the neurovasculars, because you don't want them to lose a pulse because it's too hard, and never square knot it. You have to make sure that the prescription is up to date, and if they say every 4 hours, you can have it on for 5 hours. And of course, with restraints, you want to try everything else before that. So question. Okay, over the past year, a woman has cooked meals for her family, but only eats tiny servings. She wears layered, loose clothing and now has amenorrhea. Her current weight is 95 pounds. She lost 35 pounds. Which medical diagnosis is most likely? Binge eating, anorexia, bulimia, or pica? Or pica? So B. Overly controlled eating behaviors, extreme weight loss, amenorrhea, and preoccupied with food, and the wearing very loose-fitting clothing is usually a part of someone who has anorexia. The person with bulimia, like we said before, is a normal weight. Binge eating is usually overweight. And pica refers to eating non-food items. So in this question, I didn't mention any like sand or non-food items. Okay, here's other stuff that didn't like fall under one specific category, somatic symptom disorder. So like I said before, somatic is always talking about the body. So basically, it's a psychological disorder in response to stress that causes physical symptoms. So they don't actually have anything wrong with their body, but they'll have physical symptoms because of stress, like chest pain, syncope. They'll spend a lot of time preoccupied with these symptoms. Obviously, you want the patient to have a stress outlet because that's what's causing it. You want them to verbalize what's causing it and have a support system. You also want to identify perceived benefits from the physical symptoms. So let's say someone's like trying to be sick because they want someone else to take care of them. You want to look at that. And you want to minimize that. And you want to limit the amount of time you spend talking about the symptoms because you don't want them to become like obsessive over that. The next one is dissociative identity disorder. And this is a condition where 2 or more identities control the person's behavior. This is usually caused by abuse or trauma that causes them to become like this. The patient does this to protect themselves from like stressful memories, and when they start thinking of stuff like that, they'll switch identities as a reaction, basically. The treatment is you want to integrate the 2 personalities to one while maintaining safety. You want them to journal about their feelings and triggers and use other techniques. Obviously, you want to monitor for self-harm and suicide. The last one is codependent behavior. So this is when someone enables someone else to do the bad behavior. So it's basically like, let's just say someone's married to an addict and they themselves are not an addict, but they're keeping the addict's behavior, they're keeping it a secret or covering up for them, making excuses like they're sick or something like that. So that's like codependent behavior, and don't encourage that. So thank you for watching. That's the end of the mental health video. If you want this in a PDF form, you go to my website, sararn.com, or check the link below. Bye.